conference. My name is Edwin Vasvi. I finished my neurosurgery residency 1 year ago in Varna University, Bulgaria. And now I'm working as a neurosurgeon in Varna. These online education meetings have started with Professor Hasan Kamil Sucu, the program manager of the neurosurgery department of İzmir Atatürk Training and Research Hospital, and goes on with the contributions of all the residents. Also with the contributions of the neurosurgeons who graduated from the same department, also neurosurgeons and neurosurgery residents from nearby countries like Pakistan, Georgia, and Bulgaria. I kindly ask you to keep your microphones turned off during the presentation of the lecture to avoid voice and noise pollution. You can ask your questions not by turning on your microphones, but by writing to the chat part of the Zoom program. At the end of the presentation, your questions will be asked to the lecturer and will be discussed. Mutual discussion is not appropriate for the format of our meetings. Please do not ask for your microphone to be turned on. Now, I will try to introduce Professor Gasbarrini. He has almost countless publications and numerous awards. He is one of the most prolific experts in neurosurgery. It is my privilege to present our lecturer, Professor Gasbarrini. He has finished his degree in medicine and surgery in University of Bologna. He has been working from 1998 to 2009 as medical doctor at Maggiore Hospital Bologna, Division of Orthopedics and Traumatology. From 2009, he is working as medical doctor at Istituto Ortopedico Rizzoli, Bologna, Department of Oncological and Degenerative Spine Surgery. From 2018, he is director of Department of Oncological and Degenerative Spine Surgery at Istituto Ortopedico Rizzoli. He had many fellowships programs in Strasbourg, France, Memphis, Tennessee, Spine Center, Dartmouth, New Hampshire, USA, St. Louis Spine Center, Spine Care, USA. His surgical activities from 1998 until 2020, he has more than 4,000 surgical procedures, most of them in spine surgery. His scientific activity has more than 300 publications on national and international scientific journals and 20 book chapters. His Scopus H index is 34. From 2011 to 2015, he's in the research project of the Ministry of Health entitled Comparative Effectiveness of Treatment of Degenerative Spine Disease. His teaching activities, he's professor at the School of Specialization in Orthopedics and Traumatology in University of Bologna. Welcome again, Professor Gasbarrini. Please, now you can start sharing your screen.
Let me correct you, Edwin. In the beginning of your speech, you said in the field of neurosurgery, but the professor, as you said, later is an orthopedic surgeon. Okay.
Yeah, my mistake.
It was a mistake, a small mistake.
Spine surgery.
Yeah,
yes.
Spine surgery, yeah.
It's okay. Thank you very much for the presentation. It's an honor for me to be treated like a neurosurgeon. No, no worry. For me, it's a pleasure. Sometimes I'd like to be like a neurosurgeon. Okay, I'm orthopedic in Bologna. The spinal surgeons are almost orthopedics because in Bologna there is a famous hospital that called Rizzoli Institute that started with the spine surgery for the first topic. And so we start with this presentation. Aneurysmal bone cyst seems like easy a tumor, but it's not easy. It's not easy because are about 1.4% of the primary bone tumors, and so it's rare lesion. And the 15% of the spinal bone tumors is aneurysmal bone cyst. Their prevalence is 0.32 for 100 million inhabitants here. We have 192 patients affected every year in Italy. We have a young patient, their age ranges from 8 to 26 years old, and 4 out of 5 patients are under 20 years old. And there is a little prevalence in the female. In our institution registry, from 1019 to 2017, we find that aneurysmal bone cysts are the 8.9% of all primitive neoplasm, with an additional 2.5% found in the sacrum. ABC histopathology has been matter a debate for ages. Is it tumor or not? This is a classic example of a young male with there is a disappear the pedicle in the left side, and arrive with pain, but without any neurology. And this looks like fluid level and so on. And so it's typical aspect of ABC. In this book is written by Mario Campanacci, was my mentor. And in 1909 and so on, 1009, this lesion was reported in the tumor-like lesion chapter, and so not tumor. And also in 2002, classification of tumor by the World Health Organization, we find the aneurysmal cyst in the undefined neoplastic nature category. And so it's not a tumor. But while in the same classification in 2020, we find it in the osteoclastic giant cell-rich tumors, so defined like a tumor. Again, in this last classification, we have found the definition of aneurysmal bone cyst as a benign osteoblastic giant cell-rich tumor containing multiloculated blood-filled cystic spaces. These lesions could be solitary lesions, and they are recognized as real aneurysmal bone cyst, in which we find rearrangement of USP6 gene in 70% of the cases, which CDH11 USP6 fusion in 30% of the cases. And so it looks like a tumor. And secondary lesion that are categorized like ABC-like lesion, in which we don't find this translocation. And so it's not aneurysmal bone cyst, but is a secondary aneurysmal bone cyst. And so many other tumor can have in his context aneurysmal bone-like tumor images, like chondrosarcoma, osteoblastoma, fibrous dysplasia, giant cell tumors, and some metastases, and so on. Macroscopically, they appear as a cystic spaces filled with blood, with a thin shell of reactive bone, whereas solid areas are unusual, but there is solid aneurysmal bone cyst. Microscopically, we find osteoclastic-like multinucleated giant cells surrounded by stromal mononuclear and myofibroblast cells, and fibrillar and osteoid components. And so, looks not like a tumor. The patient arrived to our attention with pain usually, sometimes with some neurologic problems, but usually it's pain. And at the MRI and the CT, osteolytic, sometimes with the rim of thin cortical bone layer. MRI and CT with contrast fluid level shows the typical aspect of fluid level. About differential diagnosis, we have to mainly distinguish aneurysmal bone cyst from telangiectatic osteosarcoma, simple bone cyst, giant cell tumors, primary hyperaneurysm, and metastases. If you see these two images that looks like in the same position and the same lesion with the cystic lesion of the sacrum, and you see at right 14 years old and at left is 42 years old. And so if I have to say what is aneurysmal bone cyst, it's possible, right? But this is giant cell tumor, aneurysmal bone cyst in the other side. And so we have to think always about something else than aneurysmal bone cyst. In this case, two similar disease images, but you can see that aneurysmal bone cyst and metastasis in the below images. And it's obvious that the treatment is completely different. Without proper diagnosis to take up the patient could be a disaster, the treatment. This is other two examples in the same site, same images, same huge mass, but one is aneurysmal bone cyst and the other is fibrosarcoma. And so going back to our case, our simple case of pathognomonic images of aneurysmal bone cyst, pay attention. Always we prefer to perform needle biopsy under CT control directly in the mass, and we perform biopsy and we see the translocation, we see immunotherapy, immunohistochemistry, and after we know that is not a giant cell tumor, not osteosarcoma, but is aneurysmal bone cyst. According to Henneking classification, the Henneking surgical staging system of musculoskeletal sarcoma, benign lesions are distinguished in inactive, active, and aggressive. 1, 2, 3. ABC can belong to each group. Inactive lesions are incidentally found. No symptoms is present. Active lesion create pain because the tumor is slowly growing, creating a surrounding reactive capsula inside the same compartment. And aggressive lesions are able to pervade tissue also outside to the initial compartment, and they do not give metastasis. Modern ABC therapy is based on the following techniques: selective arterial embolization, which we can define as the first choice, in our opinion; mesenchymal stem cells injection, second choice; denosumab therapy, third choice. And after, there are some local injection, intralesional injection that with some material, but we don't use it. Surgical treatment should be left to the cases that do not respond to less aggressive therapy, or when the spine stability or the neurological safety is at risk. If not, we prefer not to operate. The concept behind the efficacy of the local injection is osteoclast plus angiogenesis inhibition and stromal necrotic effect. Many different substances have been used over the time: calcitonin with methylprednisolone, doxycycline, phenol, bleomycina, but we think that the best injection is the injection of stem cells of the patient. The gold standard treatment nowadays is a selective arterial embolization. Its effect is the reduction of the cyst size. It can be repeated multiple times till the cyst is extinguished. In favor of this treatment are the following factors: low risk, good result reported in literature, is not effective, does not prevent surgery afterwards, in any cases limits surgical blood loss. Before surgery, when you need, it's better that you perform a selective arterial embolization. Summarizing, a selective arterial embolization is a current gold standard for ABC treatment. Selective arterial embolization should be usually repeated at least 2-3 times before significant result. And the target of the procedure is the embolization of the whole lesion in each procedure in order to prevent the revascularization. Let's see a successful embolization case. A young man, 23 years old, with paresthesia of the right arm, without any other neurological involvement, was diagnosed with C7 ABC. The lesion is highly lytic before treatment, but answered pretty well after 2 embolizations. The almost 3 years follow-up actually show a huge ossification of the cyst, both in the sagittal CT scan and in the axial one. Another therapeutic option is autologous mesenchymal stem cells injection. Was rational is to stimulate the intrinsic healing of the ABC through their inductive properties. The advantage of autologous mesenchymal stem cells are best biological effect, better differentiation onto osteogenic lineage ability, and reduced morbidity. We have reported our result in a recently published paper in selected cases, 14 cases in our series, where the ABC was stage 1 or 2, there was no significant instability, and selective arterial embolization was not an option because not feasible. Autologous mesenchymal stem cells was successfully used. In fact, the result showed increased ossification over time, improved the clinical outcome, reduction of the VAS score from 7 to 1 after 12 months. Young woman, 28 years old, with neck pain, no neurological issues. CT show a lytic lesion in the posterior arch of C1, biopsy confirmed ABC, and she was submitted to 4 selective mesenchymal stem cells injection in 1 year's time, and withdrawn from L4. We usually bring the stem cells from the vertebral body, not from the pelvis. We had a clinical and radiological good outcomes 1 year after the beginning of treatment without any pain. Another case of 13-year-old boy came to our clinic with a huge cervical mass with neck and right arm pain, but no neurological problems. Biopsy confirmed the images related suspect of ABC. After 3 embolizations, the lesion appeared to be worse and then before, and the second line treatment was therefore the autologous mesenchymal stem cells injection. And so we start after 3 injections of the ABC, result fully ossified. You can see the differences between before MSC autologous injection and after that. Also, MRI show an impressive change after the injection cycle. Another case successfully after MSC injection, 15-year-old boy with persistent neck pain after minor trauma. The MRI showed a lobulated fluid lesion. The CT guided biopsy confirmed ABC. Embolization was not feasible due to the angiographic pattern. There is 1 spinal artery inside. The 6-month follow-up has been impressive, both clinical and radiological, with complete symptoms remission. And this is the sagittal view. Another case, 14-year-old girl with progressive non-traumatic neck pain, and the evidence of imaging is an erosive lytic lesion started from C2, open biopsy, confirmed ABC. She was submitted to selective arterial embolization with vertebral artery occlusion too, but there is this preventing further embolization treatment because there is excessive risk of cerebral perfusion issues. And so consequently, she was submitted to 3 MSC injections, cycle, in the lapse over 1 year. No significant improvement at 6-month follow-up, but after the 3rd injection, from the 8th month onwards, she started to ossify more and more. And so this is one of the best treatments that we have at the moment. Now, have a look to another treatment option, still debated, is denosumab. Is off-label for ABC in our country, but considering the similarities between giant cell tumor and ABC, it has been used for ABC in some selected cases, especially when other options were not effective anymore. Denosumab is a human, you know that it's a human monoclonal antibody. It inhibits RANKL, the main osteogenic cytokine. It reduces bone resorption, is used in metastasis from breast carcinoma too. The denosumab therapy can lead to complications such as jaw osteonecrosis, sterility, and hypercalcemia. A young woman, this is an example, 28 years old, presented with neck pain and no neurological problems. MRI pattern was pathognomonic for ABC. The lesion was massively lytic. Denosumab was started in after 7 months. The justification was consistent. After 1 year, denosumab have been stopped. This is a problem of denosumab for giant cell tumor too. She had the recurrences, and consequently, she started a second denosumab cycle with a good response to the treatment. Another example, 24-year-old boy presented with severe left side thoracic radiculopathy. The first treatment is just decompression, simple, very minimal invasive decompression to relieve symptoms as soon as possible. Then he was submitted to reported embolization and in the end to MSC injection. Results were still not optimal, remain very lytic with the no new ossification. And so the decision was then to shift to the denosumab therapy for 10 months. The clinical and radiological results have been promising. And so with very good result. These are the sagittal images in the progressive ossification. At 2 years from the denosumab stop, the new recurrence happened with the lytic lesion become more evident again. She had MSC injection with no significant improvement at the moment, but with no pain. This is a case of massive ABC of L5 and sacrum treated with 7 selective arterial embolization, persistent pain, and no radiological response. And so at that time, we decided to start with denosumab with good radiological but persistent pain. And so from radiological point of view, we was very happy, but the pain was terrible. And the patient decided against our opinion to undergo surgery in another hospital. And unfortunately, he died during surgery due to the massive blood loss. And so pay attention to go inside these these huge tumors. As already started, nowadays surgery is not the first choice. It should be performed in selected cases only. Pathological fractures that present mechanical instability and a severe neurological improvement is why we operate. And the goals of surgery are to stabilize the spine, to protect and to release the neurological structure. The primary goal is not to treat the cystic lesion itself. When curettage of the lesion is performed, additional procedure could be associated, such as argon beam coagulation, phenol injection, adjuvant radiotherapy, and cryosurgery. Also, the bone could be filled with bone grafting, augmentation with polymethyl methacrylate, bioactive glass, demineralization, demineralized bone matrix, where you want to fill the cavity. In this case of cervical aneurysmatic bone cyst of C6, C7, Friday night arrived with pathological fracture of C7 in a 19-year-old male. There is a progressing of neurological impairment with ASIA D grade scale. And so posterior decompression and stabilization, C3, T1 was urgently performed in emergency. And 5 months after surgery, an important recurrence of the lesion is identified. In this picture, you can see the lesion, and 15 months after the treatment with denosumab, progressive ossification can be identified. This patient is 12 years old with an aneurysmatic cyst of L1, was affected by thoracolumbar pain and poor deambulation. No neurological deficits were present, and so she was previously treated with 2 selective arterial embolization, but after at 1 month follow-up, there is clinically and progressing spinal cord compression was present, and MRI show an increment of the cyst, and so we decided to perform a corpectomy of L1 with additional filling of bone marrow aspirated with hydroxyapatite scaffold. This is in these intraoperative pictures, the lesion could be seen before the asportation of the left one and after asportation and decompression in the right side with the stabilization. This is a follow-up at 9 months of CT. You can see the hydroxyapatite where there was the cyst. There is no compression. Clinically, there were very good recovery and resorption in resumption of daily activities. This is a follow-up at 9 months on CT scan. Clinical, where were clinical recovery or resumption. You can see that the strange things that the vertebral body come back to the original shape. In the CT, there is a comparison between 1 month follow-up and now 9 month follow-up. This is a young girl with cervical pain, is 6 years old, ABC in C6, severe instability, inflection extension, and so we decided to operate. This is the lesion, the CT scan, and the WBB score. And so we decided to perform the bulking. We prefer before to enter in the cyst, but surround very well, stay far from the lesion, and to decompress above and below, and after to have a very good decompression. In 6 years old female, we decided just to put a graft and wire and put an halo jacket for 1 month. And after few months, there was a very, very good fusion. And so this is the treatment algorithm proposed by our unit. After the ABC diagnosis is obtained, if a worsening core damage or instable pathological fracture is present, the surgical approach with the decompression and stabilization is indicated. In absence of these clinical features, a conservative approach with selective arterial embolization should be performed, with treating expert with the healing expected after 1 to 5 embolizations. If not feasible for high risk, or if healing is not achieved after 4 embolization, then infiltration with bone marrow concentrate should be attempted, and healing is expected after 1 or 2 infiltration. If not, treatment with the denosumab should be treated and started. And so in conclusion, the take-home message that ABC is benign bone tumors that do not arise from the spine, but not only from the spine. The biopsy is mandatory to obtain the correct diagnosis before start the treatment, because sometimes there is other tumors that have some aneurysmal cyst inside it. Embolization represents the first line of treatment, and you have to consider bone marrow injection and denosumab as second and third line of treatment. And surgery is indicated only in case of instability and symptomatic cord compression. And so is functional surgery, not to treat the tumor. Thank you very much.
Thank you, sir, for this professional and expert lecture. It was really a pleasure to listen to you. Can you please stop share screening now?
Yes.
Okay. Before going to the questions of our participants, I would like to ask the first question. Have you tried the bone cement augmentation of these cavities? And what is your experience and what is the outcome if you have tried it?
Usually those patients are young. And so I think that the cement is not my first option. I prefer to put something that resolve, and there is a substitution from his bone, just not to leave something that is not alive, is not active inside the young man. And so you can use, I think that is not a big problem, but in time you never know. And so I prefer to leave something that is easy to remove and without the thermal effect.
Thank you, sir. And I would like to ask one more question. When you follow up these patients after arterial embolization, when do they have again recurrence, if they have it? What kind of period they are asymptomatic after the embolization?
Usually we made one embolization, and after 40 days, the other embolization. And our interventional radiologist said, if there is a lot of circle and he stop all, or if it's difficult. And sometimes he said, I stop every vessels, and there is no vascularization anymore, and we can wait 3 months. If not, we prefer to reduce the vascularization in the first time, but 50%, and to have after 20 days another embolization to fix the other. Sometimes the most problem in embolization is Adankiewicz artery or spinal artery. And so if there is this problem, we made the first embolization just to know the vascularization, because the vascularization is important in case of surgery too. And so if you have to go to surgery, you know if you can cut these roots or not. And so it's important to know how is the vascularization of this this spine. And so after the first, if it's not effective, we start with mesenchymal stem cells injection.
Thank you, sir. This is very interesting and very new, really.
You have to think that Rizzoli started to treat aneurysmal bone cyst in 1900, and we have a lot of books in this hospital that show radiotherapy, en bloc resection, very old kind of injection of steroid and so on. But I think that this is the most effective algorithm to use to treat this disease.
Thank you very much. Now I would like to ask the questions from our participants. There is a question from Professor Kamil Sucu. First he says, very impressive speech and very impressive results indeed. His question is, can autologous mesenchymal stem cell injection and embolization be combined? If so, which one must be the first procedure?
The first is embolization. We always perform embolization. The only situation where we perform before stem cells is when embolization is not feasible. We made an angiography. Embolization is not feasible because there is a risk for the adenocarcinoma or for some artery, or is not possible to embolize for the pattern vascularization problem. We start with stem cells infiltration.
Thank you. There is contribution from Professor Haluk Berk. He says, thank you for such an excellent overview of aneurysmal bone cyst of mobile spine.
Sorry, Edwin. Professor Haluk Berk is a prominent orthopedic spinal surgeon working in İzmir, Turkey. And I want to hear his opinions if he is available for now. Professor Berk, are you here?
Yeah, he's here. I see him.
Yeah, but I think, okay, let's go on for now. And if he turn on his microphone, we can take his opinions.
Okay. There is another question from Professor Hasan Kamil Sucu regarding to CT-guided spinal biopsy. Is there any risk of bleeding and compressing the spinal cord after biopsy procedure?
Theoretically is possible. Usually is not like an angioma. Angioma is different. We prefer when we know that there is hemangioendothelioma or angioma or osteosarcoma, telangiectatic osteosarcoma. We prefer before biopsy to perform embolization. When there is a fluid level, that seems that there is not so big amount of blood, and so and not under pressure. And so I think that is not necessary to perform embolization before, but is important, in my opinion, that where is necessary to perform a biopsy, have to be a surgeon ready to operate after biopsy if there is some problem. And the same for vertebroplasty, for every procedure that is interventional procedure.
Thank you. In the context of the subject of biopsy, I would like to ask one question. What do you think of making biopsy just by X-ray, not by CT-guided biopsy?
Yes, it could be an option because it's easy to perform, but sometimes with all the images that you have before, in general, not for aneurysmal bone cyst, but in general, you know that PET scan or MRI show one one section of the lesion that is in necrosis, and some part is possible that is more active. And so with CT, you can go exactly where you want. And so, in our practice, CT scan is better, is better, and you have more successfully for the live tumor.
Okay, thank you, sir. I don't see for now any more questions. Okay, I'm gonna wait a few minutes again to see if there are more questions. And during the waiting, I would like to ask one more question. What are the most often complications that you have with embolization of this aneurysmal bone cysts? Complications.
We had during embolization of the vertebral artery, in one case, we had the loss of the visus one times for just for a few hours. And after the other vertebral artery compensated these problems. And so now, if I have to embolize to the vertebral artery, I prefer not to do it and to go to pass directly with the infiltration of the stem cells. If it's possible, I prefer not to operate directly the aneurysmal bone cyst, because in our experience, sometimes it's very bleeding, and sometimes there is not enough time to stop the bleeding during surgery.
Thank you, sir. And what is the mechanism of injecting these mesenchymal stem cells? How do you take them, and do you make some preparation?
Usually, you know that the stem cells usually you bring from the pelvis, but we have a study very well done from one doctor that worked here, Dr. Barbanti Brodan, that prove that after the bone marrow inside the vertebral body is better, is more active than in the pelvis. And so it's easy to bring from the pedicle of L3, L4, one big vertebra where there is a big pedicle, to bring the, after you bring usually 60 cc of stem cells, and after you put in the machine that concentrate the stem cells, and 60 become 5 cc, and you aspirate 5 cc from the ABC, and after inject the result of our concentration. It's very easy, very fast, and usually we perform, or in the case of C1 arch, we perform in CT scan, but usually we made it in operating theater with X-ray, normal X-ray.
Thank you very much. I don't see any more questions. Now I would like to give the word to our professor. Oh no, I see one more question from Yetkin Soyuncu. He says, thank you very much for nice presentation. I missed the first part of presentation. My question is regarding to biopsy. The lesion is cavitary and filled with fluid. How can we get enough bone from lesion? Okay,
this is a very good question, because sometimes you bring a lot of blood or fluid and there is nothing. The important thing is to have not just the shell, but have the membrane between the fluid level. And so usually if you aspirate the fluid and after you attach to the thin cells, I usually pass all the lesion and arrive in the other part of the vertebral body, and you bring a little bit of carrot of tissue in the vertebral body, because usually the aneurysmal bone cyst enter inside the cortical, the cancellous bone for 3-4 centimeter. And so don't bring just the fluid, but go inside the vertebral body.
Thank you.
Usually,
Thank you very
the
much.
aneurysmal bone cyst is in the posterior arch. In the left or right posterior arch is usually is asymmetric. And so you can go inside the cyst and arrive inside the vertebral body.
Thank you. Thank you very much, sir. Okay, I will give the word now to our Professor Hasan Kamil Sucu.
I want to thank again Professor Gasbarrini. It was a very impressive lecture. And Professor Halukberg want to get your email, and I gave him your email, probably contact with you, and we wish you see you in İzmir, in Turkey also.
Thank you.
Thank you so much.
It's a pleasure.
Thank you, sir.
For the
Bye-bye.
opportunity. Hello, and see you in Bologna. Rizzoli is waiting for you. Ciao.
Thank you so much.
Bye-bye.
Bye.